Hello and welcome to the Modesto Bee's live Q&A session on the coronavirus vaccinations. I'm Brian Clark, editor with the Modesto Bee, and I'm joined by Dr. ChrisAnna Mink, a pediatric infectious disease specialist and a clinical professor of pediatrics at UCLA. Dr. Mink is the Modesto Bee's children's health reporter on a 2-year fellowship through the Report for America program, which is an initiative of the Ground Truth Project. She is supported locally by the Stanislaus County Office of Education and the Stanislaus Community Foundation. We were lucky enough to have Dr. Mink join us in June of 2019, and who would have ever known that 6 months later we would be tapping her expertise at the start and throughout this pandemic. She's here to answer your questions, and before we start, just a reminder that Dr. Mink is providing general information and not medical advice. So if you have health concerns, please contact your provider. Also, our social media editors will be here monitoring Facebook, looking out for your questions, and we would certainly welcome the audience's participation and engagement. ChrisAnna, it's been about 11 months since our first Q&A. Feels about like 11 years ago, and so much has changed, but a lot of great news in the last week. Why don't you tell us about the 2 new vaccines?
I know, I agree with you. It feels like it's been forever since we last talked, and so much has changed. But this week, maybe there's a little bit of light at the end of our very long tunnel, as everyone keeps using that expression. And that's with the arrival of 2 vaccines receiving emergency use authorization from the FDA. And that means that we can use them because there's an emergency, not that all the studies are final and complete.
What are the 2 vaccines available?
The first one that got approved was the Pfizer-BioNTech, and the second one that just received authorization on last Friday is the Moderna vaccine. The 2 vaccines are very similar in that with their active ingredient being messenger RNA, and it's much more medical school training than everybody wanted, but just a little bit about messenger RNA. What that does, it's like a string of Lego blocks that go in and tell your DNA what to build. And they're telling your DNA to build the spike protein, you know, that picture we keep seeing of the coronavirus. And when it builds that spike protein, your body goes, wait a minute, that's not supposed to be here. And it makes an immune response to it. And the other reason that we have a little bit of medical school today with learning about messenger RNA is viruses mutate very quickly. And there's been a lot of the news this weekend about the mutations in England. Those little building blocks, just like your child playing with the Lego can switch them out regularly just for fun, the virus does the same thing. The reason we care about that is it going to impact how these vaccines are working? So far, the answer is no. That it's just been one mutation that's been recognized that actually affects the spike protein, and the immune response that our body's making to that reacts to a lot of parts of the spike protein. So far, we're doing okay.
Okay, this was something anticipated by scientists.
Actually, the viruses mutate all the time. They're well known for that. And actually, you know about that too, because every year you go for your flu shot. And the reason you have to go for your flu shot every year is because the flu viruses mutate regularly. They pick up they pick up proteins and DNA and RNA and whatever else happens to be around fairly easily, and they just change. So every year you need a new flu shot.
So are Moderna and Pfizer, are they basically the same, or are there slight differences?
Spot on. They are basically the same, with being that active ingredient of messenger RNA, but their composition is a little bit different. They're tucked into lipid bubbles, and that's because messenger RNA breaks down so easily, and those little lipid bubbles are what help it get into your cell. And then the messenger RNA, once it delivers its message, literally they just degrade. And so it doesn't affect your DNA long term. To the best of our knowledge, there aren't those kind of concerns as far as science knows. And messenger RNA vaccines actually have been studied a long time. Just this is the first one to get into use in the US.
Okay, so both take, during the vaccination process, 2 shots of each. Can you crisscross, or if you're on Moderna on the first shot, you have to have the Moderna on the second, and vice versa?
Yeah. The CDC, the Centers for Disease Control, said if you start with Moderna, you get the second with Moderna. If you start with Pfizer, you get the second with Pfizer. However, If by chance you get the other vaccine the second time, they do not recommend getting another shot, a third shot. Everyone, when they get their shots, gets a very official CDC vaccine card, just like kids who get their baby shots. Everyone knows that yellow card they have to show to school. There's a special one for COVID. And so healthcare workers are right now getting at the hospital. The hospital has that card, has that vaccine. You'll look at your card, they will give you the same thing. But you should also read the card yourself to make sure that you are getting the same thing the second time. The reason that's important is that's how we know what are the best chances of the highest efficacy. After 2 doses of Moderna or 2 doses of Pfizer, the efficacy is at around 94%. And a lot of people have been asking, what about if you only get 1 dose? And the efficacy after 1 dose maybe is around 50%. But really, you need 2 doses of the same vaccine. 2 weeks later, that's when you get around 94, 95%.
Okay, good. And if you want to see the actual card, I think we got that on the video. We were at Oak Valley Hospital on Friday watching one of their healthcare workers get that shot, and we showed the card. So go to modbee.com and read ChrisAnna's great coverage of that. What about side effects?
And that's the second most common question I get is, does it hurt? How bad is it? What's going to happen to me? And the answer is, yes, it hurts. It looks like about 85% of people say that they have local reactions of pain and discomfort. Fewer people are reporting issues of body aches and fever. It seems to be a little more after the second dose for both of the vaccines. And it seems to be a little more in people under 55 versus those over 55, at least for the Pfizer vaccine. The big safety concerns that people have been asking about, what about those allergic reactions we've seen? And it seems that the CDC is addressing those and putting out specific guidelines for healthcare workers who will be giving the shots. The real contraindication at this time because of a reaction is if you have known anaphylaxis to any components in the Pfizer vaccine. And then they have sort of precautions if you have known allergic reactions to other vaccines or other injectable medicines, shots. But right now, the only serious side effects that have been contraindications are those severe allergic reactions. I want to add one thing, Brian. We don't know long term, right? Everyone always asks, well, what's going to happen 2 years from now? Well, we don't have that kind of data on these vaccines yet. They've only been in humans over the last 2 to 6 months. Some of the early safety studies were about 6 months, but the big studies to prove efficacy, the longest follow-up we have right now is about 9 to 10 weeks. Most reactions that happen after vaccines, just historically, do tend to happen actually pretty soon within the first 30 days, but the people in those studies have been asked to be followed for 2 years.
Okay. And the side effects similar with Moderna and Pfizer?
They are similar and quite impressive for both studies. They looked at a wide age range. That would be for Pfizer. They looked from 16 to, I think the oldest was 95. And also Moderna went 18. I think the oldest is 95 in that study too. So we have a wide age range where they looked at side effects. They had enrollees in their clinical trials that reflect the United States population and that it was ethnically quite diverse. So a lot of times when a vaccine comes to market, we don't have such a wide age range and such a wide diversity. So we have data on a pretty good representation of our population.
Good. We got our first question, and it talks a little bit about this and ingredients and stuff like this. And this is from Ann Beekman. And her question is, are the ingredients different in the vaccine? Some brands need more refrigeration, for example. Why? And does it have to do with the preservatives used, or what might be the reason?
And actually, the reason is the mRNA. As I mentioned earlier, mRNA is not very stable, and it's put in those lipid bubbles. They're called nanoparticles, technically, to try and help it stay stable. But the reason it's kept for Pfizer at that minus 70 degrees Celsius kind of range is to help keep it stable. And once it's thawed, it can only stay at a room temperature for about 5 days. The Moderna uses a slightly different lipid composition for their fatty bubble. And so it's been able to be maintained at regular refrigerator freezer kind of temperatures. Those are the components that actually differ in the vaccine. There aren't specifically much else that's different. There's a few other sort of solutions, it has to be dissolved in solution. One has more potassium. Those kind of things probably are insignificant to how your body sees them.
Okay. And can you tell us, kind of refresh us a little bit, how distribution of these vaccines are going to be prioritized? We heard this morning that CVS is going to start distributing them to long-term facilities. I think there's some states that are going now. California will go on December 28th. Now, drilling down to Stanislaus County, Modesto, and how the counties, I'm not sure on that, but that announcement came early this morning. So can you kind of give us a refresher course on who goes first, and I'll write on down the line.
Sure. We all know who went first was the frontline healthcare workers, the ones who are actually taking care of known or possibly infected patients with COVID-19. And how these, and also in that top tier group are people in long-term care facilities, the residents and the staff. Those two are by a little bit different pathways for vaccine delivery. How those got established as the top priority is from the Centers for Disease Control Advisory Panel had a big meeting, and they looked at the science, like who's at most risk and who's most likely to benefit. Some of the ethics, again, the same line of risk and benefits. Is there more risk to getting disease or more risk of getting vaccine or not getting vaccine? And then the logistics or implementation. So those were really important people. Obviously, healthcare workers, we need to preserve those on the front line because they're high risk of exposure and they are intricate to the survival of everyone in the healthcare system. And the long-term care facility residents are the ones that have the highest mortality when they get infected. And as a matter of fact, in Stanislaus County, I think the mortality rate for that select senior population approaches 75% if they do get infected. So the CDC set those guidelines out, and then the states did tiers within their communities. In California, it's the California Department of Public Health, and they have 2 advisory committees to assure equity and fairness in distribution. And that's a big deal how the states can do it. For example, we have a lot of agricultural workers. Some states have a heavier amount of educators. So the states have a little bit of flexibility within the recommendations from the CDC. So now we went from the 1A group, the healthcare workers and the long-term care facilities. Next would be the group, and the CDC actually just met on this yesterday, and that group, and that is 1B, includes people over 75 because they're high risk even if they're not in long-term care facilities. And then continuing in the same tier with that 1B group are frontline, or I think our state uses the term critical infrastructure. So police, fire, ambulance, EMTs actually have a high attack rate, emergency medical techs, those folks in the library and in the ambulances. We also have education, agriculture, and food chain. Some places are saying grocery store workers, but it's really more like food chain, how people that actually get it from the farm to your table can be prioritized. Next are the other essential workers and adults that are over 65 because they also have an increased risk, but not as high as those that are over 75. After that come all the other healthcare workers that haven't yet been immunized, and then adults that have high risk conditions. Followed then generally would be healthy adults and children if their vaccine gets down to them. And I'll talk a little bit about that maybe later. I'll finish this first. And then finally is going to be everyone else that for some reason they haven't gotten into that group. You notice there's not specific priority by ethnicity, which is a concern because, African Americans and certainly in our Stanislaus Modesto area, Latinos and Hispanic population had been hard hit. But they fall into the high risk categories actually much based on their occupational risk. and including agriculture and healthcare providers. So they will get in the priority groups just based on their jobs.
I would imagine there are a lot of moms to be who are curious about whether they should get a vaccination during pregnancy, or should they wait until after childbirth. There are breastfeeding questions. Can you talk to that topic a little bit?
And again, actually, about 3/4 of healthcare workers and a big chunk of other essential workers are female, and many of those are in childbearing age. So there are no data yet that it's being gathered on the animal toxicities. First, the FDA requires that the new products are studied for reproductive effects in animals. That's ongoing. And also then in select populations that will receive the vaccine. So pregnant women will be studied. But in the meantime, the Centers for Disease Control has said that if you're at high risk of COVID exposure, such as a pregnant surgeon, then who is working in the COVID population, that they should discuss with your healthcare provider about your risk of getting the disease versus the potential benefits and the unknowns of the vaccine. So it is a decision for the women that are pregnant to make as individuals, weighing the risk and benefits. But if you look at social media feeds, there are a lot of pregnant women and women of childbearing age and healthcare providers that are rolling up their sleeves and getting the vaccine.
How about other risk groups, such as those with underlying medical conditions or weakened immune systems, those undergoing chemotherapy or maybe HIV/AIDS therapies? Is it safe for them?
Those are also groups that tend to be at higher risk of getting severe COVID, and they were actually included in some of the efficacy trials with both Pfizer and Moderna vaccines, which is quite impressive. I think between 25–30% of the subjects, the adult subjects, had at least one underlying medical condition, such as diabetes or obesity, in in the clinical trials. And so we have data that the safety and efficacy isn't different in those with underlying health conditions. But this caveat, we don't have a lot of data for those that are immunocompromised, such as someone receiving chemotherapy. They are candidates to get immunized, with the keeping in mind that they may not make as good immune response, just because that's the whole purpose of some of those therapies, is to weaken your immune system. And thus, you not only does it help you for your disease, but you might not respond as well to the vaccine.
Okay. We have a question from a participant here who's watching, Rox Burnell from Facebook, asks, if you've already had COVID, do you need to have the vaccine?
That's a great question. And the studies knew that was also an issue. And they looked at people who didn't have any evidence of previous COVID vaccine. They measured their antibodies before they got in the trial. They measured them throughout the trial. And they found that there doesn't seem to be a difference if you have COVID and you get a vaccine, or if you've never had COVID and you get the vaccine. It does boost up your immunity. With this caveat, there are a lot of caveats, and I want to add, I should have added this before, this is what we know today. If nothing else, in everyone attending medical school over this past year, things changed with COVID, and we're learning new stuff like hourly sometimes. But what we know today is that after you've had COVID, you are probably protected for at least 90 days after you've had that. So you may consider deferring getting a vaccine until at least after that time period, because you already have some protection. These official recommendations are out but evolving. So I say just keep seeing what's up with posting on the Centers for Disease Control websites.
Yeah, and I see that. I remember that throughout last spring and the summer and fall, the CDC changing guidelines here and there. So yeah. I'm sure we're all in a learning process right now, especially health officials. How have the vaccines been studied in children? And
yeah, one of the good news about this whole crazy pandemic is that children seem to do fairly well if they get infected. And so they weren't as much of a priority for getting a vaccine into them. However, no matter what vaccine, even vaccines that are destined for children, say some of the meningitis and some of the baby shots, it's always studied in adults first, because adults can understand risk and benefits of participating in a clinical trial, right? For kids, their parents make those decisions for them and until they reach a certain age, and then they also provide assent to participating in studies. So it's very regular to go adults, older children, younger children in any vaccine. That's not a surprise. For this vaccine, especially since kids tend to be faring fairly well if they do get infected, not everyone, and I don't want to dismiss how that some kids have had severe disease. So what the companies did was they went for the people at highest risk first, which just makes good sense. And for the CDC, for ruling it out, they went for people at highest risk first. However, it doesn't stop there. Pfizer has already been licensed down or approved down to age 16, and they have studies underway for 12 to 17-year-olds. Moderna and Pfizer both are planning studies in younger children. I don't have the timeline. It hasn't really been posted yet. I do know the Pfizer study for 12 to 17-year-olds is happening, including in Northern California at the Kaiser Vaccine Center. And I think, even though I say kids have done generally well, they are really good at being carriers and being asymptomatic. So eventually it will be that probably everyone, regardless of age, will be candidates for immunization.
Okay. And when, speaking of children, when you talk about children, how young? Should a 1-year-old be getting a shot, a 2-year-old?
We don't know yet. We just don't know yet. It hasn't been looked at younger than 12 at all right now. And it does look like sneak peeks for the adolescents seem to be just as effective and, just as immunogenic, making good immune response as in the older people or the older adults. But we don't have any data in anybody under 12 yet.
Okay, and I just thought about this. Are all dosages the same to size?
Yeah, right now they are.
On what size you are. So, okay.
Right now. And it's a great question, because for flu vaccine, we don't give it under 6 months. And the reason we don't give it under 6 months is because babies have a lot of reactions to it. And that's why everyone who's caring for a baby and has to get flu vaccine, because we can't immunize the babies. And for little kids with flu vaccine, we give them half doses, right? And then once you get over a certain age, you get just the regular adult. That could be something that happens with coronavirus. We just don't know yet.
I'd like you to look into your crystal ball, and this will be the first time, and this won't be the last time I ask you this, or I ask you to look to the future during this. But when can we expect a rollout to the general public? I think that's what a lot of people want to know.
My crystal ball is not working very well, or I would be on a beach in Hawaii without a pandemic. But it's a reasonable question that everybody wants to know. And there are a lot of different answers that we're getting. Alex Azar from Health and Human Sources, the U.S. Health and Human, said maybe as early as spring. He thinks that the vaccine's being churned out and that he's going to be able to get it out. Those with a little less rosy glasses think it's more realistic that it will be summer and potentially into fall. I would put my money, and I don't bet for summer, for most people being immunized. And most, to get to herd immunity, you need at least 60 to 70% of the population to be immunized with this vaccine, which is lower than some other vaccines. For measles, it has to be 95% of the population have really good herd immunity. So that's hopeful, if those predictions are correct, that we only need maybe 2/3 of the population to be immunized to really have good herd immunity. Will it be in time for everyone to go back to school is another question I've been asked. How about the vaccine so everyone can go back to school? What I would guess is that not all of the children will have vaccine in time for school, since now especially they start in August. But it may be that their teachers and all the other educators that are essential to getting schools open may be immunized, which is hopeful. So I would be optimistic, but realistic that we just have to see how often the vaccine gets rolled out. There are going to be glitches and problems. Everything is new. With this vaccine, there's, getting a new registration system in place, getting just logging and tracking everything. So people shouldn't be surprised if something goes awry. And we've already had that a little bit with the ordering of the vaccine and distribution for what the states were expecting this week. But there's still hope,
Yeah.
that
How
they'll
many
be
vaccines? How many vaccines are there in the pipeline?
There are at least 4 additional vaccines in the U.S. pipeline that look promising in the early studies. And globally, there are more than 60 vaccines that are being developed. So the World Health Organization is tracking closely of what looks good in different countries, and so that some of the developing nations do not get left out. Because they're also being hard hit with the pandemic. So we have 2, which is really exciting, but there may be more on the way, and they may not all have the same efficacy, but they may have easier storage requirements. They're just having more is better at this point.
Okay. And we have a question from Michael Tillett in Merced. How long is the vaccine good for? Will it be an annual thing, or does this last longer?
That's a really good question, and we don't know. Again, I need that crystal ball that Brian keeps thinking that I should have. We have, as I mentioned, follow up on the people in the study so far, about 9 weeks, 10 weeks at the longest. And it very well may be that it could turn into an annual thing. What's kind of interesting is if you are around and paying attention in 2002, 2003, we had a SARS outbreak, and then that virus just went away. So this coronavirus, which is very closely related to that one, doesn't seem to want to go away. It may be that we need an annual vaccine, just like we have needed with flu vaccines.
You'd mentioned the word herd community a couple of minutes ago. Can you tell us a little bit about that?
Sure. Herd immunity, it means just like it sounds. Once enough of our herd is protected, that if you didn't particularly get the shot, you're probably still protected because the virus isn't getting into your herd. And it comes from, I think, literally from cows and how they looked at protecting herds for different animal zoonosis, animal diseases. So that's what it means. And so if we get 2/3 of our herd immunized, it will help even other members who haven't quite had a chance to get vaccine. Now, more, again, is better. If everyone is vaccinated, that decreases the chance of the virus getting into the community at all. Because there's always going to be some people not eligible for vaccine. As I mentioned with flu, babies under 6 months aren't eligible for flu vaccine, but we get immunized to protect them. They're part of our herd.
Okay. Once I've been immunized, do I have to wear a mask? Do I have to practice social distancing? Of course, I always need to wash my hands, but do we have to practice that?
Yes. Unfortunately, at this moment, we don't have enough data to prove that the vaccine protects you from getting infected. What that 95% protection is against you getting illness. And that's kind of, again, welcome to medical school 2020. Getting infected means the virus gets into you. Getting sick means the virus makes you have symptoms. A lot of people, up to 40% of people, are infected with this coronavirus with no symptoms. And so we don't know if the vaccine will take away the asymptomatic carriage of the virus. So that you still need to wear your mask to make sure that you don't spread to others, and follow all those mitigation things that we've known so well this year. Wear your mask, social distancing, and hand hygiene. And I want to add a little bit about mask. Back when we did our first Q&A, CDC was saying, don't wear a mask. We don't think it does anything. Well, we've learned that was wrong. Yes, masks not only protect you from spreading, just like a surgeon in the operating room, it protects you to some degree from getting infected. So even though you're vaccinated and you probably will stay well, you don't want to spread it to others. So yes, still wear your mask, still wash your hands, still maintain your social distancing. You don't want to give this killer disease to somebody else.
And is that just going to be a way of life forever, or at what point do the masks come off, so to speak?
Well, we don't know the future yet. Again, with the 1918 pandemic, there were a lot of mask wearers then, until finally 2 years later, they're like, okay, we're all right. The virus isn't spreading anymore. They didn't have vaccines then, but we have the perk of hopefully we can slow down the spread with our immunizations.
So some sort of normalcy, probably 2022 at the earliest.
That may be realistic, yeah.
Yeah. We had another question from Abe Villa of Modesto. This kind of goes back, and we answered this a little bit. Will the current vaccines work against the new variants that are being detected in the UK?
As I mentioned a little bit earlier, we think so. Right now, the biggest mutations don't seem to be part of what produces the spike protein, and the vaccine's efficacy is against the spike protein. So the answer at this moment is we don't think it's going to be a problem for the immunizations losing their ability to work.
Okay. Question from another reader. This was beforehand. What does a vaccine feel like going into your body? Of course, we've all heard about Pfizer having to be stored at minus 70 degrees. Moderna is more like your typical vaccine, just in a regular refrigerator. What have you heard?
This was one of the questions from the Friends of the Library in Modesto, which is one of my favorite groups since I've been in Modesto, and it's a great question. We see those ultra cold freezers and everybody in gloves and stuff. The vaccine actually is mixed in a liquid to get it in solution, and it has to be at room temperature before it's given. And when I was out at Oak Valley, which was a very fortunate experience, the healthcare worker said, just feels like a regular shot. And I think that sums it up for us pretty nicely. Yeah.
Good. Should you get the vaccines or the vaccine if you've had severe reactions to other vaccines or medicines or foods?
Yeah. People with allergies should discuss even sort of severe food allergies, discuss it with their healthcare providers. But the CDC thinks that, yes, they should go ahead and be considered vaccine candidates. They recommend that people with those kind of allergies be observed for 30 minutes instead of the usual 15 minutes, just to be safe. And that the vaccine be given in an environment where they can handle severe allergic reactions. So in a healthcare facility, basically. For the future is hopefully that for just the healthy population and the lower risk individuals, that the COVID vaccine can be done like the drive-through flu vaccines that we've seen this fall. But if you have a history of severe allergies to foods or other medicines, you're probably going to need to take it in a healthcare facility, even in the future. And as I mentioned earlier, if you have a history of anaphylaxis, especially to any of the COVID vaccine components, then that's the only contraindication that is considered right now. And we've had 2 or 3 of those reported in the US. And I just want people to keep in mind, you're going to see those severe reactions, and they're going to be in the media because they get a lot of attention, but you should expect them. If something happens 1 in a million, and we have 328 million people in the United States, we're going to see those severe reactions. People should be reassured, though, that the FDA and the CDC are still monitoring for those things.
And if it was widespread enough, those companies or the CDC would pull it off the shelves, so to speak.
Right. That's what I mean. That's what I meant by saying they're still monitoring for it. It's still part of healthcare providers. Anybody giving immunizations are asked to report those things so that they can monitor how frequently they're occurring.
Okay. This might be a question for somebody in the California Department of Public Health, but it's from Kirsten Epps in Modesto. Is the vaccine going to end up being mandatory for children to go to school or to be in public school?
We don't know yet. I just don't know. There are some of those discussions happening at the CDC, the federal level, but we don't know.
Okay. So how do I go about getting a shot? I mean, once it gets to the public, do I have to go to a hospital? Do I have to go to my doctor? Is the county going to mandate we go somewhere else? Have you heard of kind of what the plan is going to be? Who's going to make sure to follow up and all those kind of logistical things?
I'd say stay tuned. Those things are being discussed pretty much daily as the vaccine continues to roll out. How are we going to get it to people? Not just the general public, but okay, how are we going to get it to everybody who's over 75 if they're not in a long-term care facility? Where are they going to go? What's going to happen? The logistics are being worked out as the vaccines are being rolled out. So we don't have all of the answers. I should have mentioned this earlier. For long-term care facility residents and staff, it's through a different mechanism than for healthcare workers. For healthcare workers, the vaccine comes into the county and goes to facilities. For long-term care facilities, it's a relationship between some of the pharmacies, including CVS, Walgreens, and some of the managed care insurance programs. They have a relationship that it's coming from the government through a organization called McKesson. They pick up the vaccine. Those pharmacies are totally responsible for getting it to the long-term care facilities. Those pharmacy systems may be used for some of the other at-risk groups, which is realistic for mobile people over 75, but a challenge for people that aren't able to just go to their pharmacy. So there's probably going to be more than one mechanism to get it out to the other high-risk groups and to get it to the general public, but it's not written down just yet. As I mentioned a little bit ago, though, one hope is to have for the general public is drive-throughs, just like we saw with the flu vaccine this past fall, which certainly would make it a lot more accessible if it's in places out in the communities for some of the people that aren't as mobile.
Okay. And I would encourage anyone watching to send us your questions. We look forward to them, and you've asked some really good questions so far. We are rolling toward the end of our time a little bit. So just as a heads up, get your questions in now. As an infectious disease specialist, ChrisAnna, how impressed are you that the vaccine is on the market roughly a year since the virus displayed itself?
It's pretty amazing, right? But what I wanted to say is that what I'm impressed with is the science. People are a little concerned about, wow, it happened so fast. It's kind of like someone becoming a superstar overnight after they've been in small venues for 30 years. People have been working on SARS vaccines since the 2002 outbreak, and even some messenger RNA and different viral components since decades. And you can hear Dr. Fauci talk about all the research that's been happening at NIH and in the companies. So yes, it happened this fast to actually get this particular one made, but it's built on the pyramid of decades of science. And so I'm overwhelmingly impressed with the science and incredibly happy with the speed for this final tip to get it out to the public. I want to also take a little minute to say I did some of my training at the FDA Office of Vaccines, and those scientists there are some truly unsung heroes, and that they work tirelessly on all kinds of things to make sure the products that get to your arms are safe and effective for the use. And I want to thank them personally.
Yeah. We have a couple more questions from Lori Odello Kirby in Fresno. Can someone that's had the virus get it again? And how long do the antibodies last?
They're working on that. It looks like, yes, there are some reinfections that are being reported, not as many as it seems to get into the news, but there are some, there have been a handful of reinfections that have been reported. The antibodies last at least 3 months. That's how long the studies have for us to let you know. But it may not just be the antibodies that protect you. Again, back to med school 2020, you have antibody part of your immune system, and you also have cells as part of your immune system. So even maybe after your antibodies go away, the cells in your immune system still remember the virus. And so if you get an infection again, your cells might say, hey, wait a minute, this is trouble, and crank out antibodies fresh, even though they might not be floating around in your blood at that moment. So we look at antibodies, but the studies are also looking at how your immune cells are your memory immune cells are primed in case that virus comes back.
Okay. We have another question from Kevin Phipps in Sacramento. If you have side effects to the first dose, should you get the second dose as scheduled or check with your provider before getting that second dose?
Perfectly phrased. The answer is, if you had reactions to the first dose, you probably will have reactions to the second dose. If they're not severe, the CDC says, yes, still go ahead and get the second dose. The protection is worth it. After you have, and actually in all the studies, there were more reactions after the second dose than after the first dose. And they just recommend that you use like Tylenol, ibuprofen, whatever that helps for you to feel comfortable afterwards. To get through dealing with those reactions. Except, again, anaphylaxis. If you have a severe anaphylactic reactions, then no, you can't get the second dose.
So when you talk about severe, that's what you mean, because everyone has their own definition of what severe could be, and there could be different interpretations. So
if you have high fever, and there were some rare reports of swollen lymph nodes, and that makes sense. Your lymph nodes are part of your immune system. And so they see this foreign virus in your shot. Then the lymph nodes kind of get tender and swollen. Those kind of things you can discuss with your doctor or your healthcare provider, but probably aren't contraindications to getting the second dose.
And when you say high fever, are we talking about 102, 103, or 101?
Yes.
What?
Yeah.
102, 103? Okay.
Yeah, it's like for adults 101.5. They start counting fever at 100.4, but high fever would be over 101.5, 102, somewhere in there. Yeah.
Okay, good. Another question from Daryl Lamke in Merced. Will there be any copay if I have Medicare? And this is a very good question, because we haven't talked about the costs and stuff, and I'm sure that's on everyone's mind.
Yeah. The vaccines are supposed to be free. Once it gets out into doctors' offices or even in pharmacies, they may have an administration charge, and you should ask your specific insurance provider, is every part of the vaccine and vaccination covered? Does that make sense? The vaccine itself is free. Paying for the time for whoever's giving you the shot and the supplies that go with it, they might have ways to charge you. So just ask before you go. Right now, there's not a concern because it's healthcare providers in healthcare settings or long-term care facilities where it's already in the part of the pharmacy program. But as it moves down to the other tiers, that's a good question.
Yeah. So if you have like a $20 copay, if you're lucky enough to have a $20 copay when you show up, it might be that, but the cost, okay.
Yeah. The vaccines themselves. Sorry. Something happened to the sound. The vaccines themselves. The Pfizer's. Something's wrong with sound, Brian. Are you okay now? I'm getting feedback. Are we okay?
Okay.
Are we back? Yes. Are we back? Good.
Okay.
I forgot what the last question was. Sorry.
I think we had the technical, because I was going to ask you to call in to look into your crystal ball again.
Oh,
And I think that's
thank
when
you.
things went sideways. You didn't want to ask an answer to the question. So look, in the next 5 or 10 years, is there going to be another pandemic, another situation like this, another coronavirus, another, how concerned should we be about having to go through something like this again? And certainly we're not out of the woods yet.
Between 1918 and the next pandemic was the Hong Kong flu, as I recall. Although polio was in there, but the Hong Kong flu was 1968. So we made it 50 years without such a major impact on Earth. But we haven't gone that far in between them. So looking, we had Ebola, we had SARS in 2002, we had 2009 with the H1N1 flu. So just looking at my retro crystal ball, it looks like things are happening more often. So I'm going to learn from science and say that it very well may be on the rise. And I have heard plenty of scientists saying that global warming is a factor. And of course, the more global travel we have, the easier it is for things to spread. So I think something to this degree, I hope not. I hope lessons are learned and that we are more rapidly prepared and more openly communicating with our colleagues around the world, but it wouldn't be a surprise to see another pandemic in our own lifetimes. I forgot to add something, Brian, back when we were talking about children, and I want to take this opportunity to say, yes, we may not be able to immunize kids against COVID right now, but you certainly can make sure they're immunized against everything else that is recommended, especially influenza vaccine. Influenza and COVID can have a lot of the same presentations and can be can make kids miserable, and flu does kill kids as opposed to what we've seen mostly with COVID, that it's not a high mortality with children. So I really encourage everyone to make sure, grab out those yellow cards, make sure your kids are up to date, and it's not too late to get your flu shot.
Okay. Well, it doesn't look like we have any more questions. I do want to note that as I said, the news of the 2 vaccines are great. Still certainly not out of the woods as we continue to see daily, especially in Stanislaus County, but throughout California, the positivity rate remaining at about 15%. Deaths, high death rate in Stanislaus County. We're no way out of the woods. We still need to wear masks, practice social distancing, wash your hands, don't congregate at Christmas. I know, we look at post-Thanksgiving and the number of cases and the impact it's having on our hospitals. So we still have to remain extremely vigilant and probably for the next, for a long time, to come until we can get all the vaccines out. So with that, I want to thank Dr. ChrisAnna Mink. Always a joy to speak with you and get your take on these medical issues, especially the coronavirus. Been extremely helpful to us and to our readers. And I want to thank everyone for participating. Check at modbee.com for all the latest on the coronavirus, for ChrisAnna's stories, as well as Ken Carlson and all our medical coverage coming up as the vaccines get rolled out. So any last words, ChrisAnna?
No, just follow those mitigations. Wear your mask. Stay 6 feet apart. Don't gather for Christmas, because the only thing worse than you getting COVID is to know that you've given it to someone who didn't survive.
Okay. Good advice. Well, everyone have a great holiday week, and we will talk to you soon. Thanks again for participating.
Bye.